So welcome once again. This is the weekly IPHAM webinar, and you can see the link to all of the webinars in the chat box. And we welcome all of you and encourage you to attend the seminars in the future. My name is Tamara Isakova. I'm one of the directors of the centers in IPHAM, specifically the Center for Translational Metabolism and Health. And I'm excited to introduce the speaker today, who is a colleague in the Division of Nephrology and Hypertension and also a core member of the Center for Translational Metabolism and Health. So Dr. Anand Srivastava is going to speak to us today on a very important problem that continues to affect all of us every day. And I'll just tell you a little bit about Anand as I've gotten to know him over the last few years. He is an assistant professor in the Division of Nephrology and Hypertension, and he trained in St. Louis University School of Medicine, UT Southwestern, the combined fellowship in nephrology at the Brigham and MGH, and he also obtained a master's in public health at the Harvard School of Public Health. His research currently is on biomarkers of kidney injury, both chronic kidney disease as well as acute kidney injury, and he has an award from the NIDDK to advance this work. This topic for today is actually something that Anand started to get involved in as all of us were still trying to figure out in the spring how the COVID-19 pandemic is going to affect all of us and how to pivot. And Anand motivated the staff as well as colleagues in the center to participate in this national study, which is the Stop COVID study. It involved very meticulous data entry after swiftly obtaining an IRB and lots of collaborative calls with colleagues nationally on this data set that he'll talk to us more about. So without further ado, I will let Anand take over. I'll just mention that if you have questions during the presentation, please put them in the Q&A box and we will get to them at the end of the talk. Anand, please go ahead.
Great. Thank you very much, Tamara, for such a warm and kind introduction. And thank you to the organizers at IPHAM for the invitation to speak here today. I'm going to be speaking to you about a talk that is entitled COVID-19 from Case Reports to Clinical Trials. Here are a list of my disclosures, none of which are relevant for the purposes of this talk. So this is the state of affairs currently of coronavirus disease 2019 or COVID-19. So as of yesterday, there's been over 56 million individuals infected globally with over 1.3 million deaths and 11.5 million infected in the United States with over 250,000 deaths. And if you look at this chart, which is from the Johns Hopkins Resource Center for Coronavirus, you'll see that we are here in this green line. And here we are in the third surge of coronavirus with rapidly increasing confirmed new cases. But really where I want to begin is kind of at the beginning, and probably the beginning for us. So on December 31st of 2019, officials from China reported a cluster of cases of pneumonia in people associated with a seafood market in Wuhan, China. A week later, this was confirmed to be a novel coronavirus. And on the 19th of January of this year, a 35-year-old gentleman who did not have really a significant past medical history presented to an urgent care clinic in Snohomish County, Washington. He complained of a 4-day history of cough and subjective fever. He checked into the clinic, he put a mask on in the waiting room. He waited approximately 20 minutes before being taken into an examination room. He disclosed to all the health officials that he had returned to Washington 4 days prior to presentation of his symptoms after visiting family in Wuhan in China. He sought medical care because of the symptoms, but also because he saw an alert from the CDC about a novel virus that was being transmitted. At the time of presentation, he was breathing normally on ambient air. He had a mildly elevated heart rate. His physical exam revealed some rhonchorous breath sounds, which are really just rattling of the lungs that one might hear with pneumonia. His chest x-ray is actually on the top right of the screen, and that really did not reveal any abnormalities. So after they collected blood, urine, stool, and nasal swabs from him, they discharged him home in isolation. A few days Later, he was tested positive for SARS-CoV-2, the virus responsible for COVID-19, and he was later hospitalized and placed in airborne isolation. The chart on the left really shows the time course of his illness, and here, day 1 will be hospital day 1. And really, you'll see that over the course of his illness, he had fever almost for a week, he had a cough, he had fatigue throughout, he had intermittent nausea, vomiting, and diarrhea, all symptoms that one would expect with a viral illness of this type. As his disease course and hospital course progressed, right around day 6 and into day 7 on illness day 10, his chest x-ray started to change and his clinical signs started to change. And actually the individuals in care of him gave him an investigational antiviral agent that we now know is remdesivir on hospital day 7. And subsequently after that, his clinical condition continued to improve. Importantly, I think in this case report, the authors suggest that even though he was given this antiviral agent, remdesivir, well-powered clinical trials were needed to adequately determine if this is a treatment that is efficacious against COVID-19. So while this case report was rich of data, it really only showed data for one individual, and it was clear that we needed to know more about COVID-19. This table shows some of the evidence that was needed to better define the epidemiology of COVID-19 and the types of studies that were required. While I cannot go through all of the data, there are several important key questions that were required to be answered. Namely, what is the spectrum and the full spectrum of disease? The range from asymptomatic to mild illness to severe illness during hospitalizations and fatal illness. How does one's underlying conditions affect their susceptibility to the virus and the ability to transmit it to others? And what are the risk factors for severe illness and death? This one is really key, so we can identify the groups most likely to have poor outcomes, and we could focus on them for prevention and treatment. As we started to see this play out, we started to learn more about the virus. We know that SARS-CoV-2 attaches to the ACE2 receptor, the angiotensin converting enzyme 2 receptor, which is a membrane-bound peptidase that acts as a protein ligand for COVID-19, and it allows viral entry into cells and damage of target organs. ACE2 is actually relatively expressed in type 2 pneumocytes in the lungs. It's also in the kidney. It's in the vascular endothelium. And really, you can see really a systemic illness. You can see sepsis, systemic inflammation, hypercoagulability, as we know. And you can see neurological symptoms. You can see liver injury, thromboembolic disease, cardiac injury, hemodynamic shock, acute kidney injury, or AKI, and of course, the acute respiratory distress syndrome, or ARDS. And as we started to learn more about the clinical characteristics of patients, this is we needed retrospective cohort studies to be able to kind of define the prevalent characteristics of individuals with severe disease and in the severest forms of the disease. This is a cohort of nearly 1,100 individuals from over 500 hospitals in Wuhan, China, through the end of January of 2020. And realistically, what it demonstrated was that individuals with more severe disease and individuals who reached an endpoint of ICU care, the need for mechanical ventilation, or those who died, we saw that individuals who were older, who were of male sex, who had pre-existing comorbidities like coronary heart disease, diabetes, hypertension, who had white blood cell counts that were low, actually lymphocytes to be specific that were low, and who had high inflammatory markers were more likely to have severe disease overall. If you look closely, actually, there's no mention of body mass index or race from these studies from China. But we needed to know more in the United States. So what were the characteristics? Were they similar or were they different? So this is actually the first and the largest case series of 5,700 patients that were hospitalized in New York City. It was conducted at Northwell Health, which is the largest academic health system in New York. And these are individuals that were admitted from early May to early April. And again, similar findings are seen that individuals who have older age, being of male sex, hypertension, diabetes, is relatively similar to Wuhan. What was different is that we were actually able to see some of the racial breakdown. It's not a disease that affects one race in particular. It definitely affects others. We'll be more on this later. And also we saw, as we saw in our patients, that we saw that obesity, individuals who were more obese, they actually seem to be more prevalently having COVID-19. And if you look at this, actually, it's 60% of the patients had a body mass index over 30 with COVID-19. And in this cohort, it appeared that about 12% required mechanical ventilation, and 21% of the individuals died. If you look at the inflammatory markers of this group of individuals, you can see that they have higher levels of C-reactive protein, which is 30 times the upper limit of normal, ferritin levels that are 2 to 3 times upper limit of normal, and D-dimer levels, which can be a marker of interruption in the coagulation cascade, also 2 to 3 times the upper limit of normal. This is actually work that was performed here at Northwestern from colleagues in our divisions of neurology and neurocritical care, that not all the manifestations are your typical fatigue, nausea, vomiting, and fever, but rather you could have neurologic manifestations as well. And this group sought to see the frequency of the neurologic manifestations. And they determined that in approximately 500 individuals that were consecutively followed here in our health system, that essentially 80% of the patients may have some form of neurologic manifestation, which is most commonly myalgias, headaches. You can develop encephalopathy, dizziness, loss of taste or dysgeusia, and loss of smell or anosmia, which actually definitely made it into the press headlines as well. When they went on to look and see what are the predictors of encephalopathy, they identified that individuals who had severe COVID-19 was an independent predictor of encephalopathy. Also, individuals who had a prior history of neurologic disorder, they had a shorter time from the diagnosis of COVID to hospitalization, those who had chronic kidney disease, and those who had a lower white blood cell count. All were risk factors that were independently associated with encephalopathy. But in particular, individuals who had severe COVID-19 infection that was defined as requiring mechanical ventilation through the use of a ventilator, that was the strongest risk factor for the development of encephalopathy. As I mentioned, hypercoagulability was an issue in COVID-19. We were seeing that patients were in their heightened inflammatory state were having problems with both arterial and venous clotting disorders. And in this study of over 3,000 patients hospitalized in New York City, a thrombotic event occurred in 16% of patients. It also shows a breakdown in this graph on the left of the different types of thrombotic events. You can see that individuals presented also with myocardial infarction, deep vein thrombosis, pulmonary emboli, strokes, and other types. If you look here on the graph on the right, in the dark blue are in the dark purple are the individuals who had a thrombotic event, and in light purple, individuals who did not. You can see that whether or not you were in the ICU, that individuals who had a thrombotic event actually had higher rates of all-cause mortality. And then when they looked in multivariable models, that individuals who had a thrombotic event were at 1.8-fold increased risk of death. We mentioned a little bit, this is a topic that's near and dear to me, of course, with regards to individuals who develop kidney injury. And some of the early studies from Wuhan suggested that the incidence of kidney injury were relatively low on the scale of 5 to 15%. This is a study from New York City that studied over 4,000 patients and demonstrated that patients admitted to the hospital often had acute kidney injury. And in fact, we often define this using a serum creatinine value in the blood. So stage 1 would be a 50% increase in creatinine, stage 2 would be doubling, stage 3 would be a tripling, or the need for dialysis. And these are people who never needed dialysis in the past. And that individuals hospitalized, nearly 50% of them had some form of kidney injury, which was more severe in patients in the intensive care unit. And I'll talk more about that a little bit later on in the talk. What we definitely saw and what was important to understand, and this is data from the CDC, is that COVID-19 has disproportionate effects on different racial groups as well as individuals of different ethnic backgrounds. So compared to individuals who are white and not Hispanic, if you are American Indian, Asian, Black or African American, Hispanic or Latino, you are at increased risk for developing COVID-19, being hospitalized for COVID-19, and dying from COVID-19. Now, a lot of additional research is required to determine what are the factors that underlie this, whether or not it's related to the intersection of quality of care, access to care, or other socioeconomic factors that need to be teased out. But, you know, not all of our suspicions were correct. So as we started to learn more about individuals that were affected, time and time again, as I mentioned, we saw that individuals who had a history of hypertension, diabetes, coronary artery disease, and heart failure were more susceptible to severe illness. So one thing that runs in common with these patients is that they often are on angiotensin converting enzyme inhibitors, or ACE inhibitors, or angiotensin receptor blockers, or ARBs. We also knew that SARS-CoV-2 enters through the ACE2 receptor. So a rather interesting and potentially concerning debate was whether or not these drugs, ACE inhibitors and ARBs, may increase the susceptibility of COVID-19 or a more severe form of COVID-19. The potential biological rationale is shown in the figure, that SARS-CoV-2 can attach to the ACE2 receptor and enter the cells and cause damage. Well, if ACE2 is an enzyme that physically counters renin-angiotensin aldosterone system activation, and it's the functional receptor to SARS-CoV-2, and preclinical studies suggested that RAS inhibitors like ACE inhibitors and ARBs could potentially increase ACE2. Does this mean that our patients are at risk for a more severe form or developing COVID-19? Well, there was insufficient data to support whether or not these observations and preclinical studies translate to humans. The implications of this are large. Namely, ACE inhibitors and ARBs are first or second line agents for the management of hypertension. They've been known for over 20 years to slow and improve outcomes in patients with systolic heart failure and diabetic kidney disease. So stopping the medicines could lead to significant deteriorations in the health of many of our patients that intersect across a number of medical specialties. And dare I say that the suspicion led to some degree of panic amongst the medical community as well as amongst patients. Well, this is a population case control study in the Lombardy region of Italy. They included over 6,000 patients that they included as cases who tested positive for COVID-19 between mid-February and mid-March. And they matched them to over 30,000 control patients without COVID-19. And they matched them by age, sex, and place of residence. So in this graphic here, I show you the odds ratio for COVID-19. On the left side is individuals is based on ACE inhibitor use, and on the right side is based on ARB use. So this is the line of unity in the middle. So in all of the participants that are included in this study, that if you see it cross the line of unity, it would suggest that there's no increased risk or no decreased risk. In fact, it suggests that in all participants, if they were on ACE inhibitors, there's no increased risk for the development of COVID-19 being on the drug compared to individuals who are not on the drug. If you look at ARBs, you see the same thing. If you look at subgroups, mild to moderate illness, critical illness, male or female, or by age, you do not see any increased risk for being on an ACE inhibitor for the development of COVID-19. Now, this is one study, and I can't share all of them with you, but this has been replicated in other studies that were in other populations in other countries, and some work even by our own Dan Battier here in our division contributed to this literature as well. But what about critically ill patients? So I've discussed with you more about hospitalized patients that included some degree of ICU level of care, but not specifically focused on critically ill patients. Well, we know that these are the sickest patients. And some of the early studies, and this is a case series that was published in the New England Journal, that first described 24 patients who were critically ill with acute hypoxic respiratory failure and confirmed COVID-19. So in these 24 patients, you'll see here a representative image of one of the patients of their chest imaging findings on chest x-ray on the top, and then their chest CT scan on the bottom. And if you remember back to the initial slide, you would see that this is actually a significantly different picture than an individual who had relatively mild illness. And what I show on the right is essentially the clinical course of all of the 24 patients. And I put here that almost all of them required some form of mechanical ventilation, the use of a ventilator. The 4 individuals that did not, 3 out of 4 of them died. And it's because they actually had a do not resuscitate order already in place. So the mortality rate in this case series was 50%. A large number of individuals with severe COVID-19 in the intensive care unit had a relatively high mortality rate. But we needed to know more about individual risk factors and potentially hospital level risk factors because of the potential for need of resource allocation. So I was privileged to be part of a multicenter cohort study. Tamara had mentioned at the beginning of the Stop COVID study, which stands for the study of the treatment and outcomes in critically ill patients with COVID-19. And really, as I mentioned, it's a multi-center observational cohort study of critically ill patients in intensive care units across the United States. Much of the data to this point of starting this in mid-March was that they were really limited to single center or regional data. And this now, to date, has now included over 5,000 patients across 68 hospitals, impressively over 400 study investigators. And all of the data was actually manually abstracted from the patient's medical records with over 800 data elements per patient. Notably, this is an unfunded project. This was just individuals who really cared, who wanted to learn more about this illness. And there are really three primary goals of Stop COVID. One is to investigate the clinical features and outcomes of critically ill patients with COVID-19, namely death and acute organ injury like acute kidney injury, acute respiratory distress syndrome, or thromboembolism. We wanted to perform causal inference analyses of the effects of the treatments on outcomes and assess interhospital variation in the treatments and outcomes. First, we kind of define some of the timing of the acute organ injury that you can see. So on the x-axis is actually the days from symptom onset, and then on the y are all the different forms of organ injury or adverse outcomes. So we can see that approximately 4 to 6 days after symptom onset, individuals might be hospitalized. Approximately 1 to 2 days after that, they might need ICU admission. And we saw that around that time they had respiratory failure, usually prompting ICU admission. We see that individuals developed acute kidney injury approximately 2 to 4 days after that. And around the 16-day mark from symptom onset is on the median when people unfortunately passed away. When we looked at the prognosis of patients with organ injury, we see the overall 28-day mortality was around 35%. And if you look at all the different forms of organ injuries that individuals could incur during the hospitalization, you'll see the different mortality rates. So with ARDS, which is approximately 75% of the cohort, the mortality rate was around 40%. If you look at acute kidney injury, we said that mortality rate was around 54%. If you combine organ injury, which unfortunately often happens with multi-organ dysfunction, you start to see that when you add respiratory failure and acute kidney injury, 55%. You add in hemodynamic shock, to 66% of the individuals would die. We also found that actually mortality varies by region and hospital. So if you actually look at this, that in the West Coast, we saw that the mortality rates were the lowest. And then in the Midwest, which is where we are, around 28%, and the highest in the Northeast. If you attended medical grand rounds just a few days ago, Susan Russell gave a nice summary of our data here at Northwestern, and our mortality rate was somewhere in the ICU around 18%, which is actually lower than some of the others that have been seen in the Midwest. And if you look across the different regions, relatively similar age groups, relatively similar demographics, similar numbers of comorbidities, and use of the mechanical ventilator on ICU day number 1. When we adjusted for other factors, including comorbid conditions, we also still saw a significant variability actually across different hospitals. And these are for hospitals that all contributed at least 15 patients. So if we see this, we can see mortality rates as low as under 20%, and we can see rates almost as high as 80%. So we wanted to identify what are some of these risk factors that are associated with death. Well, some things continued to show up, like we saw earlier. That if we looked at more granularly, that increasing age increases the risk of death, particularly hinging around the age of 60. So after you age above 60, we saw that the mortality at 28 days was much higher. If you look then, and like we saw earlier, that if you looked at someone who was male sex, also increased risk. Almost a stepwise relationship with increasing BMI, body mass index, and risk of death. Coronary artery disease and active malignancy. The next slide shows additional variables that we found as well. So with worsening levels of hypoxemia on ICU admission, so that is judged as by the PaO2 to FiO2 ratio. So it's really the ratio of the level of oxygenation in your blood to the amount of oxygen being delivered to you. That with a lower number suggests worse levels of oxygenation. So with almost stepwise relationship, worsening levels of oxygenation on ICU admission, increased risk of death. You had worse liver injury based on a sequential organ failure assessment score, which really looks at multiple factors within each organ that may assess their acuity of illness and severity of injury. You have increased risk of death. Almost a stepwise relationship with worsening kidney function upon ICU admission and the risk of death. And a factor that we probably were not expecting was that if you look at the ICU size of the hospital, so the number of ICU beds in the hospital, if you use as a reference group of greater than or equal to 100 beds, our hospital would be included in that, that actually with less ICU beds, you saw that there was an increased risk of death. And I think we were not expecting to see that. And I share this with you because of resource allocation that was definitely in the mainstream media. A lot of talk was about ventilator use. And of course, I have a specific interest in this because of my specialty, but that other resources started to become scarce in other areas of the country. And that potentially that it wasn't just ventilators, but also that people who started to develop kidney injury required dialysis, and dialysis machines became scarce. Both, if you care to look at these, right, interesting stories about resource allocation, and unfortunately, the troubles that a family faced about a family member who was unable to receive dialysis in a timely fashion. This led some of the charge for us to figure out some more information about acute kidney injury and dialysis in patients with COVID-19 who are critically ill. So if you look at our cohort of individuals in this analysis of almost 3,100 individuals, we saw that the rate of acute kidney injury requiring dialysis, again, individuals who never required dialysis before, that 21% of them required dialysis in the ICU, and 63% of them died. And then if you look at the people who actually made it to discharge, that still upon discharge, about a third of them were dialysis dependent. If you, though, survived and you did not require dialysis upon discharge, about 2/3 of those people could have complete recovery of their kidney function, and 1/3 of them could have some partial recovery, which means that their kidney function still was not normal, and they may have had resultant chronic kidney disease because of the severity of injury. So what are some of the factors that are associated with acute kidney injury in its severest form requiring dialysis? Very similar. Individuals with higher body mass index have lower kidney function reserve, so lower kidney function upon ICU admission. Individuals who had worse hypoxemia, worse oxygenation. And also what has been shown in some other studies from Wuhan, that individuals who had interruptions in their coagulation cascade, as seen by an elevated D-dimer that was greater than 2,500, was also independently associated with the need for dialysis. In red are other variables, in black are the other variables in the model, and in red are other ones that were also significantly associated with the need for dialysis. Namely, if you were of male sex, you had hypertension, diabetes, if you were of non-white race and had active malignancy. Now, there has been some anecdotal reports of poor outcomes in critically ill patients with COVID-19 who have had in-hospital cardiac arrest. And this prompted discussions on the futility of cardiopulmonary resuscitation, or CPR. So a single center study from Wuhan found that 3% of patients who received CPR survived 30 days. Therefore, the implementation of a do not attempt to resuscitate policies in this setting have been controversial. The arguments for not attempting CPR have been considered in settings where the supply of ICU beds would be limited, combined with knowledge of poor survival in patients after in-hospital cardiac arrest. Well, in this cohort of now including almost over the 5,000 patients that were in our cohort, about 14% of them had cardiac arrest, so 700 patients. Almost 60% of them received CPR. 12% of them actually survived a hospital discharge. And in those, slightly over 50% of them had only mild or no cognitive impairment. Interestingly, the most common arrhythmias that were seen at the time of CPR was a pulseless electrical activity, that's like 50% of the patients, asystolic function, about 24%, and only 4% had a shockable rhythm and ventricular fibrillation. So what are some of the independent factors that are associated with cardiac arrest in the hospital? Again, we came up and saw that actually the number of ICU beds, so lower number of ICU beds associated with in-hospital cardiac arrest. Higher age groups. If you were Black compared to a non-white Hispanic, you were at increased risk. And then, of course, individuals who had a worsening severity of illness score as by their modified SOFA score, also in hospital cardiac arrest. It is of interest, based on what I told you with regards to the rhythms that were seen at the time of CPR, as well as the fact that coronary artery disease and congestive heart failure were not associated with in-hospital cardiac arrest, would suggest that it may not be just the comorbidities that underlie that play a dominant role for in-hospital cardiac arrest, but just the severity of illness that these patients face could be more of the driving factor. Importantly, I did mention almost 60% received CPR, means 40% did not. And in all of those individuals, there was a do not resuscitate order in place. And importantly, none of the centers had a policy in place for routinely withholding CPR. The survival rate of 12% is better than 3% that was seen in the previous single center Wuhan study. So we've kind of gone through early part of case reports to observational studies and risk factors in both hospitalized as well as severely critically ill patients. But what does this translate, and what have we done to treat the patients in these scenarios? Well, I guess I'll start with remdesivir. So remdesivir is an inhibitor of the viral RNA-dependent RNA polymerase that has an in vitro activity against SARS-CoV-1 and the virus that causes Middle East Respiratory Syndrome, or MERS. So this is the final report of the ACT-1 trial of over 1,000 patients. It's a double-blind, randomized, placebo-controlled trial of IV remdesivir, randomized in a 1-to-1 fashion as compared to placebo. So individuals received either 200 milligrams of remdesivir on day 1, followed by 100 milligrams for up to 9 days after that. This included 60 trial sites across the world, including 45 in the United States. And they randomized and they stratified by study site and disease severity upon enrollment. The primary outcome in this trial is actually the time to recovery over 28 days, which is based on an ordinal scale. So the scale goes 1 through 8. And so it's really the time to recovery to a score of 1, 2, or 3, which is essentially not being hospitalized with little to no limitations of activities, or being hospitalized with just need for infection control issues, but not actively receiving oxygen or receiving active medical care in the hospital. So what they saw was that in all participants, you can see that individuals who received remdesivir had an increased likelihood of having recovery over 28 days. And the median time to recovery was 10 days in individuals who got remdesivir and 15 in those who did not. Important to know, and look at the subgroups, is that what about individuals who did not receive oxygen? So if they weren't receiving oxygen, while the trend towards significance is there, this confidence interval includes 1 and does not seem to be significant. What about in individuals who were receiving oxygen? This is probably where we saw some more of the benefit. So in individuals who were receiving oxygen at the time of remdesivir allocation, there is a significant benefit to time to recovery over 28 days. How about in individuals who were receiving high flow oxygen or non-invasive mechanical ventilation? Again, does not appear to be significantly beneficial as compared to placebo. And then in the sickest individuals, those who are receiving mechanical ventilation or ECMO, also unfortunately does not seem to be beneficial over placebo. I will say, I'm not showing this here, but there was a signal for decreased risk of mortality at 14 days, as well as a signal at 28 days, but just missed significance. So it seems that remdesivir may improve the time to recovery with an unclear benefit on mortality. What about convalescent plasma? It's got a lot of press in the media as well. So convalescent plasma is a source of antiviral neutralizing antibodies. It is plasma from individuals who have recovered from COVID-19. The strategy has been used to fight other illnesses in the pre-vaccine era, like polio, measles, mumps, influenza, SARS, varying levels of success. There was evidence that suggested that plasma from survivors of COVID-19 contain receptor binding domain specific antibodies with potential for antiviral activity. So actually the first 2 studies in this forest plot are actually from the FDA Extended Access Program. And actually this data, which was in preprint and still remains in preprint actually, was what granted emergency use authorization by the FDA. So they looked at individuals and they looked at if you gave convalescent plasma within 3 days of the illness versus those who got it after 3 days. And if you looked at the outcome of 7-day mortality, it actually did appear there was a significant benefit in individuals who got it early versus those who got it later. And also a similar signal for 30-day mortality. Now, this is an observational study. So what about in randomized control trials? Well, this is actually a trial, small trial that came out of China, an open label randomized control trial where they compared individuals who received plasma compared to usual care. And they actually looked at the time to recovery in ordinal scale, similar to what was in the remdesivir trial. They also looked at 28-day mortality. Now, this trial actually had to be stopped early because there were no new cases in Wuhan after March 2nd at the time. So this showed a trend towards significance for 28-day mortality, but it was not statistically significant. A trial that was massively underpowered to look at 28-day mortality. Now, I'll tell you that the primary outcome for odds of clinical improvement within 28 days was also not significant. There was a signal potentially for individuals with severe disease to potentially have clinical improvement, but again, a small trial that was not definitive. The largest trial to date is in the PLACID trial, which was published not too long ago. Another open label randomized controlled trial at nearly 40 sites in India. And it randomized individuals to plasma versus usual care. And they looked at the outcome of worsening of oxygenation to a PaFiO2 ratio of less than 100 or death at 28 days. And what they saw in this trial, unfortunately, is that there does not appear to be a significant benefit for this outcome in individuals who receive plasma versus usual care. Hydroxychloroquine has been talked about for a long time, and it has been in preclinical studies and what we know that chloroquine and hydroxychloroquine are widely used in the treatment for malaria and rheumatic diseases. The FDA authorized emergency use authorization for its use in March, and guidelines initially stipulated its use in hospitalized patients. This is an observational study that examined the use of hydroxychloroquine in individuals who received it and those who did not in New York City from early March to early April. Most of the patients received it within 48 hours of their ER visit. So because it's an observational study, there are a lot of imbalances between the groups of individuals who received hydroxychloroquine and those who didn't. So they applied inverse probability weighting to attenuate some of those differences. And what they saw was that in individuals who received hydroxychloroquine versus those who did not, there was no significant benefit for the outcome of mechanical ventilation or death at 28 days. Well, this is still an observational study. So how about a randomized controlled trial? So in a randomized controlled trial of around 500 patients that looked at 3 arms, hydroxychloroquine with azithromycin, an antibiotic used for pneumonia, hydroxychloroquine, and a control group with the primary outcome of a improvement in clinical status as based by a 7-level ordinal scale. So again, 1 through 3 would be those that would be in the group of not requiring much hospital level of care or no hospitalization at all. You see here at the bottom that the odds ratio for recovery was not different when you compared hydroxychloroquine as compared to placebo, when you compared hydroxychloroquine with azithromycin as compared to placebo, or when you compared hydroxychloroquine with azithromycin compared to hydroxychloroquine alone. So this would suggest that there is not much benefit with the use of hydroxychloroquine, and it confirms what was shown in an observational study. Well, those are still relatively small, you could say. So what is ongoing currently is the randomized evaluation of COVID-19 therapy, which is the recovery trial. This is a randomized controlled open label, multi-arm adaptive clinical platform trial in hospitalized patients with COVID-19. It includes, now to date, I believe that they have enrolled over 17,000 patients. This is being done at 176 national health service organizations in the United Kingdom. And essentially they will screen individuals, they randomize them to a number of therapies that include hydroxychloroquine, lopinavir, ritonavir, which I'll talk about shortly, dexamethasone, azithromycin, tocilizumab, convalescent plasma, REGN-CoV-2, which is a monoclonal antibody that the president received when he was ill with COVID-19, as well as aspirin. And all of these will be compared to usual care. And then their primary outcome is mortality at 28 days. A secondary outcome was length of stay, mechanical ventilation, need for dialysis, cardiac arrhythmias. So if you thought that the hydroxychloroquine trials were already too small, they tested hydroxychloroquine in this trial. So in nearly 5,000 patients who were randomized in a 1-to-2 fashion of hydroxychloroquine versus usual care, they saw that in individuals who were randomized to receive hydroxychloroquine, there was no significant benefit in its use as compared to usual care for the outcome of 28-day mortality. If you actually look at some of the secondary outcomes here, that in all of the secondary outcomes, there also is no significant benefit. If you look at actually the outcome of discharge from the hospital in less than or equal to 28 days, This would suggest actually that there is a decreased likelihood of discharge from the hospital within 28 days in individuals who received hydroxychloroquine. So this would suggest, after multiple testing across a number of trials, that hydroxychloroquine is not helpful for reducing mortality in individuals with COVID-19. So lopinavir is an HIV-1 protease inhibitor, which is combined with ritonavir to increase its plasma life. Lopinavir is also an inhibitor of SARS-CoV's main protease, which is critical for replication. In vitro, lopinavir has inhibitor activity against SARS-CoV, SARS-CoV-2, and Middle East respiratory syndrome coronavirus. So again, in the recovery trial, in a 1-to-2 fashion, randomizing individuals to lopinavir, ritonavir versus usual care, they saw that there's no significant benefit in providing this medication to reduce the risk of all-cause mortality at 28 days. What about dexamethasone, a steroid that can be given to suppress the immune system? Now, this is an important one because it actually did change clinical practice. So in the recovery trial, in a 1-to-2 fashion, giving dexamethasone versus usual care. So if we look on the far left, we'll start there. In all participants, you look at the 28-day mortality in individuals who were given dexamethasone versus usual care, and you see that actually there was a significant benefit, a 17% reduced relative risk of all-cause mortality at 28 days in individuals who received dexamethasone. If you look more closely, actually, that if you looked in the individuals who received invasive mechanical ventilation, the benefit seemed to be even more pronounced. And if you looked at individuals who were just receiving oxygen, you also saw that there was a significant benefit with dexamethasone. But interestingly, in individuals who did not receive oxygen, you did not see a significant benefit. And this would suggest, because the confidence interval includes 1, that it is not a significant benefit for dexamethasone in individuals who are not receiving oxygen. This led to the use of dexamethasone in individuals who are receiving oxygen and who are in those who are critically ill to reduce their risk of mortality. What about tocilizumab? So we talked about before that individuals who have COVID-19 have a heightened inflammatory state. And one of those inflammatory biomarkers that you might see is interleukin-6. So tocilizumab is an antibody against interleukin-6. So this is actually data from our study in Stop COVID that looked in an observational fashion to look at the administration of tocilizumab and its association with mortality at 28 days. So again, because it's an observational study, there are imbalances between the groups, and we went through a number of analyses to look at how to balance the groups, and we applied inverse probability weighting to attenuate differences between individuals who received tocilizumab versus individuals who did not. So on the left side, you'll see that based on our results, it suggests that individuals who received tocilizumab had almost a 25% decreased hazard of 28-day mortality compared to individuals who did not receive tocilizumab within 3 days of ICU admission. If you look at the subgroups on the right side, we looked at a number of different subgroups, and actually, if individuals received tocilizumab within 3 days of their symptom onset to the intensive care unit, it seemed to be the most pronounced benefit in that group. And then also, if you looked in the individuals who were the sickest of all of them, so these are critically ill patients with an PaFiO2 ratio of less than 200 and the need for mechanical ventilation, we saw that the benefit was most pronounced in that group. And again, this is an observational study. Try to do it as diligently as we could, but it still requires confirmation in randomized controlled trials. But what do some of those trials suggest? So actually in the same issue, these next two trials were actually published. So this is the RCT TCZ COVID-19 trial that actually, they looked at the composite primary endpoint of entry to the ICU with invasive mechanical ventilation, death, worsening hypoxemia across 24 hospitals in Italy. The mortality rate in this group was actually quite low. It was less than 3%, suggested the cohort of individuals that they recruited probably were on the earlier spectrum of illness. And what they saw was that there actually was no benefit in the use of tocilizumab as compared to standard of care for managing patients with COVID-19. And another trial, again, published in the same issue, that looked at individuals moderate to severe pneumonia with COVID-19, so a slightly sicker population. They saw that in a similar size of a population, that individuals who reached, as compared to usual care, for the outcome of death, invasive mechanical ventilation, or other forms of aggressive oxygenation, that they just barely met their efficacy point for decreasing the risk for that primary outcome. When you look, though, at survival at 28 days, now this trial will be underpowered for that outcome. It does not appear to be significant in this trial. The very next day, this trial was published in the New England Journal of Medicine. And this is a randomized, double-blind, placebo-controlled, randomized control trial. And they randomized individuals in a 2-to-1 fashion of tocilizumab versus placebo. And they looked at the outcome of mechanical ventilation or death. And they saw that in this population, unfortunately, even though there's a trend towards significance, the confidence intervals are wide and does not appear to have a significant benefit in reducing that outcome. If you looked on an ordinal scale of clinical worsening on the ordinal scale, again, no significant benefit. And if you look at discontinuation of oxygen supplementally, also, you do not see a significant benefit. Now, taking these trials into consideration, the Stop COVID study that we performed, that was in severely critically ill patients. If you looked at the next 2 trials that I mentioned, one had an earlier disease in the spectrum, one a little bit more moderate, and this would also match more of the moderate disease spectrum. So there are differing populations to be tested, and looking at a harder outcome of all-cause mortality requires a much larger study overall. Although as of this morning, I had a sneaking suspicion that something like this could happen given the explosion of literature that surrounds COVID-19. Now, this is not a true press release from this trial, but this is actually REMAP-CAP, which is a randomized, embedded, multifactorial adaptive platform trial for community-acquired pneumonia. It has an estimated enrollment of over 7,000 patients to test multiple therapies. They said today that as of this morning, that in their trial of slightly over 300 patients, that tocilizumab appeared to have a benefit on survival and length of organ support overall. Now, again, this is not a true press release. This one on the right is a Twitter feed, and so this is not primary results, but you can see how some of this is changing relatively rapidly in this space. But we still need to see the full results to be able to evaluate this. I will share that this is a study that has been in preprint now just about a month ago, and this is the World Health Organization Solidarity Trial. And these are some of the interim results. And we're expecting the final results hopefully soon. But this is over 11,000 patients, and they very similar in design to the recovery trial. They tested a number of therapies. They tested remdesivir, hydroxychloroquine, lopinavir, and interferon. So we talked before about remdesivir and how it had some degree of a modest benefit for improving the time to clinical recovery, but a signal, but not necessarily a benefit for 28-day mortality. The primary outcome in this trial was actually 28-day mortality. And in their preprint that has not been finally published yet, it suggests that actually there is not a benefit for remdesivir for 28-day mortality. Although consistent with the prior results that I shared already in observational studies and other randomized trials, this is consistent to suggest that hydroxychloroquine, again, no benefit on 28-day mortality. When you looked at lopinavir versus placebo, that again, individuals who received lopinavir, no benefit on 28-day mortality. And if you look at the drug interferon used in other, as an antiviral agent in other diseases, also no benefit on 28-day mortality. Well, I will say that despite what I've shared with you, which is relatively sobering thoughts on a lot of different treatments that are being tried, it is impressive how far we've come thus far. But one interesting piece is that it appears that the COVID-19 mortality rate is in fact declining. And if you go back to March as compared to now, this is actually published from 3 hospital systems in New York City, it does appear that the in-hospital mortality is changing. And whether or not this is related to a change in the virulence of the virus itself, because individuals are more educated now and we try to practice social distancing and hopefully masking appropriately, or if it's related to treatments and our ability to treat these patients more appropriately in well-resourced situations, still remains to be seen, but it appears that the mortality rate is declining. Now, while we've talked about a lot of different treatments and the spectrum of disease that can be seen, I think it is important to keep in mind that there is hope on the horizon. And this has probably filled most of your news feeds for quite some time, but just in the last 2 weeks, really, both Pfizer and Moderna have suggested that both their vaccines are over 90% effective. And in doing so, and Pfizer just released about a day and a half ago, some of the safety data that looks very reassuring as well. We'll have to be seeing more of the data as this unfolds, but this is definitely hope on the horizon. So to summarize, I wanted to end by saying that the pandemic really has been a true lesson in epidemiology that really began with case reports, goes to observational studies, moves to clinical trials, and even vaccine development. There's still a need to confirm our observations in cohort studies and test their therapies in randomized trials. Importantly, we've seen that positive and negative studies continue to teach us valuable lessons. There were times where our suspicions were wrong and needed to be verified in a testable fashion. The treatment summary that I would provide is that remdesivir has modest effects on clinical recovery time, unclear benefit in mortality. Convalescent plasma may help early in the disease, but again, unclear benefit in mortality. Dexamethasone appears to reduce mortality in individuals with COVID-19 who have more severe illness, particularly those who require oxygen or some form of invasive mechanical ventilation. Tocilizumab may have benefit in COVID-19, but requires testing in larger scale clinical trials, and we'll await the results of some of the ongoing trials. Hydroxychloroquine and lopinavir do not improve outcomes in COVID-19. Treatment for COVID-19 may not be a one-size-fits-all. We need to still identify and target populations for the right treatments at the right time. I think the dexamethasone story is a good example of that. And we anxiously await the final results of ongoing randomized clinical trials, namely Recovery Trial, WHO Solidarity Trial, which I shared some preliminary results, REMAP CAP, as well as ACT 2, which I did not talk about, but that combines baricitinib with remdesivir as well. So with that, I'd like to say thank you and acknowledge a number of individuals. Can't thank everybody, but in particular, within our own division of nephrology, a lot of the members contributed a lot to hard work to be able to gather all of the data for Stop COVID. Our collaborators in the Division of Pulmonary and Critical Care, particularly Rich Wunderink and Jackie Cruiser, facilitated our access to the data. And of course, I can't thank all of the Stop COVID investigators, but I will start by thanking the site PIs at the Brigham and Women's Hospital, colleagues and friends of mine, and Shruti Gupta and David Leaf. And lastly, I'll just close on a more personal note. Thanksgiving is around the corner, so I think I'd like to say that I am thankful to work in a health system. It continues to try to deliver care at the highest level for our patients. It empowers us with resources to participate in cross-disciplinary clinical care and research collaborations. In particular, our general medicine, pulmonary critical care, infectious disease colleagues, all of the nurses, respiratory therapists, dialysis nurses who deliver exceptional care. And of course, we can't not think about and thank all the individuals who transport, deliver food, and clean rooms for all of our patients with COVID-19. Last, of course, thanks to the NIH for funding support, Dixon Translational Research Initiative, and RP30 and UGO Kidney for infrastructural support. And I'm happy to take any questions, and thank you for your attention.
Thank you very much. Unfortunately, we can't clap, but you deserve a round of ovation. That was really a nice summary. We are going to take a couple questions, and people can put in questions into the Q&A box. And while we wait, since you ended on a personal note, I wanted to ask a personal question, and that is, what are some of the lessons for you personally as an investigator, as a physician, as a human being that you take away from your involvement in the COVID-19 research?
Oh, that's a great question. Thanks, Tamara. I mean, you know, it's interesting because it really began with a phone call from a colleague at the Brigham. And we soon learned that if you just really want to learn about something, and it's about a topic that was important, that you could corral enough people who also believed in it to gather the resources and figure it out. And I think that we try to leverage a lot of our backgrounds and biostatistics and epidemiology in a way that we could try to align and deliver information on a larger scale that was important. So I think at the end, not to be cliche, but when there's a will, there is a way.
Got it. Got it. There are some questions coming in, so I thought I would just see what you think about them. There's a question about mortality changes, declines from spring to summer, but not much since then. Any thoughts on that?
Yeah, so from spring to summer, right. So it's hard to know. I mean, the cases had definitely gone down overall in the country. It's unclear if some of the trial results helped with this. And so we're not sure if this is related to changes in the virulence of the disease, but I guess in this next surge, we'll really see if whether or not the mortality rates have really declined, or whether or not resources in the hospitals are just better equipped. And if we start to face another surge that overwhelms hospitals, if the mortality rates could be different.
Okay. There's another question about the mutation of the virus, if that affects infectivity or morbidity or mortality.
Sure. Yeah. So it's possible. It's possible, and it's possible that it could be related to that, or it could be that we, as a larger society, even though masking and social distancing isn't always happening as regularly as a lot of us would like in this country, but it's possible it could be a multitude of factors that could be related to why the infectivity or morbidity mortality is changing.
Okay, and then one last question here about Regeneron or any other monoclonal antibody treatments.
Sure, yeah, so it's a great question. So Regeneron monoclonal antibody is shown some benefits early on with regards to reducing clinical severity of illness. Obviously, as I mentioned, the president received that therapy is probably where it got a lot of press. We're still waiting on it to be tested in randomized clinical trials. I mentioned that the recovery trial will be testing that. So I think it's important to note that these emergency use authorizations are important in a time of a pandemic to be able to try new therapies, but it still requires testing in a randomized fashion to confirm our suspicions. And the other one I'll mention is bamlanivimab, difficult to say, that was recently also approved for emergency use authorization. That also is now more for, I think, on the outpatient side to reduce clinical severity in people with milder illnesses overall.
Great. Well, in the interest of time, we're going to stop here, but I want to thank you again for a very comprehensive review of a very important topic, and especially for inspiring all of us to use our skills to solve important problems and answer questions that still remain out there. Thank you very much, and thank you everyone for joining.
Thank you.